Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of Glycogen Storage Disease Type 1, also known as von Gierke disease, designed for general pediatricians. This is a disorder of glucose metabolism that classically presents in infancy with severe fasting hypoglycemia and a strikingly enlarged liver. We will work through 14 carefully crafted clinical cases, covering clinical presentation, examination findings, the underlying enzyme defect, the metabolic consequences, laboratory investigations, the difference between the A and B subtypes, diagnosis, dietary management, and the long-term liver, kidney, and metabolic complications. Let us begin. Question 1. A 4-month-old boy is brought to the emergency room with irritability and a brief seizure. His mother notes that he cried inconsolably after sleeping 4 hours overnight. On examination, the heart rate is 160 beats per minute. Weight and length are at the 25th percentile. There is a markedly protuberant abdomen and firm hepatomegaly extending 5 centimeters below the costal margin. Blood glucose is 1.8 millimoles per liter, which is 32 milligrams per deciliter. What is the most likely diagnosis? Option A, Glycogen Storage Disease Type 1. Option B, Diabetes mellitus Type 1. Option C, congenital hypothyroidism. Option D, galactosemia. The correct answer is option A, Glycogen Storage Disease Type 1. The hallmark combination here is severe fasting hypoglycemia together with marked hepatomegaly. Onset is typically between 3 and 6 months of age, as overnight fasting intervals lengthen after early infancy. The hypoglycemia is severe, with glucose falling below 2.2 millimoles per liter, and the liver is firm, smooth, and non-tender, extending well below the costal margin. The seizure and irritability arise from neuroglycopenia, low glucose supply to the brain, and not from a primary neurological cause. By contrast, galactosemia presents with jaundice and E. coli sepsis, while congenital hypothyroidism causes lethargy with a normal liver and no hypoglycemia. Question 2. A 2-year-old girl with known hypoglycemia episodes presents for follow-up. She has a round, full face and a well-nourished appearance. Examination reveals height at the 5th percentile, massive hepatomegaly without splenomegaly, and a protuberant abdomen. There is no jaundice and no lymphadenopathy. Which combination of findings is most characteristic of Glycogen Storage Disease Type 1? Option A, splenomegaly, jaundice, and a cherry red spot on the macula. Option B, massive splenomegaly, lymphadenopathy, and hepatomegaly. Option C, doll-like facies, hepatomegaly without splenomegaly, protuberant abdomen, and short stature. Option D, jaundice, cirrhosis, and coagulopathy. The correct answer is option C, doll-like facies, hepatomegaly without splenomegaly, protuberant abdomen, and short stature. The doll-like face comes from a rounded appearance with full cheeks caused by fat redistribution. The hepatomegaly is massive due to both glycogen and fat accumulation, but importantly, there is no splenomegaly. The protuberant abdomen reflects liver and kidney enlargement, and there is no ascites. Short stature results from chronic metabolic derangement and growth delay. The key distinguishing feature is the absence of splenomegaly, which helps rule out portal hypertension and reticuloendothelial storage diseases. Question 3. A 6-month-old presents with severe fasting hypoglycemia, massive hepatomegaly, lactic acidosis, hypertriglyceridemia, and hyperuricemia. Genetic testing confirms Glycogen Storage Disease Type 1A. Which enzyme deficiency is responsible for Glycogen Storage Disease Type 1A? Option A, glycogen phosphorylase in the liver. Option B, debranching enzyme, amylo-1,6-glucosidase. Option C, branching enzyme, amylo-1,4-to-1,6-transglucosylase. Option D, glucose-6-phosphatase. The correct answer is option D, glucose-6-phosphatase deficiency. Glucose-6-phosphatase is the final common enzyme that releases free glucose from glucose-6-phosphate, the end product of both glucose breakdown and gluconeogenesis. In type 1A, the defect is in the glucose-6-phosphatase catalytic subunit, encoded by the G6PC gene. In type 1B, the defect is instead in the glucose-6-phosphate translocase, encoded by the SLC37A4 gene. In both subtypes, glucose cannot be released into the blood, producing hypoglycemia. First-line diagnosis is molecular genetic sequencing, which is non-invasive. Importantly, the glucagon stimulation test is contraindicated because it worsens lactic acidosis without raising glucose. Question 4. A 6-month-old with confirmed glycogen storage disease type 1A has severe fasting hypoglycemia and massive hepatomegaly. Labs show lactic acidosis, hypertriglyceridemia, and hyperuricemia. GluCO6-phosphate accumulates in hepatocytes because it cannot be converted to free glucose. Which set of metabolic consequences best results from diversion of excess glucose 6-phosphate through alternative pathways? Option A, lactic acidosis, hypertriglyceridemia, and hyperuricemia. Option B, metabolic alkalosis, hypocalcemia, and hyponatremia. Option C, isolated hypoglycemia without other metabolic abnormalities. Option D, hyperammonemia and elevated amino acids in blood. The correct answer is option A, lactic acidosis, hypertriglyceridemia, and hyperuricemia. When glucose 6-phosphate cannot become free glucose, it is diverted through several alternative pathways. Through glycolysis, it is converted to pyruvate and then to lactate, producing lactic acidosis, with lactate often between 4 and 10 millimoles per liter. Through lipogenesis, it drives excess fatty acid synthesis, producing hypertriglyceridemia and a risk of eruptive xanthomas. Through the pentose phosphate pathway, it fuels purine synthesis and uric acid production, producing hyperuricemia. Together with the underlying hypoglycemia, this gives the classic metabolic tetrad: hypoglycemia, lactic acidosis, hypertriglyceridemia, and hyperuricemia. Question 5. A 10-month-old infant is referred for recurrent irritability and 2 episodes of loss of consciousness during the morning hours before feeds. Investigations are ordered. Which laboratory combination is most consistent with glycogen storage disease type 1? Option A, elevated ammonia, low glucose, and elevated glutamine. Option B, low lactate, elevated ketones, and moderate hypoglycemia. Option C, low glucose, high lactate, high triglycerides, high uric acid, and mild transaminase elevation. Option D, elevated ferritin, low ceruloplasmin, and elevated copper in urine. The correct answer is option C, low glucose, high lactate, high triglycerides, high uric acid, and mild transaminase elevation. This is the classic metabolic laboratory tetrad. Blood glucose is low, below 2.2 millimoles per liter, reflecting severe fasting hypoglycemia. Serum lactate is high, between 4 and 10 millimoles per liter, with a pH below 7.35. Triglycerides are markedly elevated, often between 5 and 25 millimoles per liter, with a risk of eruptive xanthomas. Serum uric acid is high, above 420 micromoles per liter. The liver transaminases are mildly to moderately elevated. A vital clinical pearl: ketones are absent or very low in these hypoglycemic infants. Absent ketones in a hypoglycemic infant should make you think of glycogen storage disease type 1. Ammonia is normal, which rules out organic acidemias and urea cycle disorders. Question 6. 2 siblings are diagnosed with glycogen storage disease type 1. Child 1 with type 1A has severe hypoglycemia, hepatomegaly, and elevated triglycerides. Child 2 with type 1B has identical metabolic features, plus recurrent fevers, oral ulcers, perianal disease, and 3 hospitalizations for bacterial infections. Which feature best distinguishes glycogen storage disease type 1B from type 1A? Option A, a more severe degree of hepatomegaly. Option B, an earlier age of onset in the newborn period. Option C, a greater degree of hypoglycemia requiring more frequent feeds. Option D, neutropenia with recurrent bacterial infections and inflammatory bowel disease. The correct answer is option D, neutropenia with recurrent bacterial infections and inflammatory bowel disease. The metabolic picture of type 1A and type 1B is essentially identical. What sets type 1B apart is immune dysfunction. The SLC37A4 mutation causes a translocase defect, so glucose 6-phosphate cannot enter the endoplasmic reticulum within neutrophils, leading to neutrophil dysfunction and neutropenia. This produces recurrent bacterial and fungal infections, oral ulcers, perianal disease, and a Crohn-like inflammatory bowel disease. Treatment includes granulocyte colony stimulating factor, targeting an absolute neutrophil count above 1.0 times 10 to the 9th per liter, and the emerging use of empagliflozin, which reduces glucose 6-phosphate toxicity in neutrophils. Type 1A has the metabolic features only, with no immune dysfunction. Question 7. A 5-month-old boy presents with fasting hypoglycemia, massive hepatomegaly, elevated lactate, and hypertriglyceridemia. Glycogen storage disease type 1 is strongly suspected. Which is the preferred confirmatory diagnostic method? Option A, molecular genetic testing with G6PC or SLC37A4 gene sequencing. Option B, glucagon stimulation test using 1 mg of intravenous glucagon with glucose monitoring. Option C, urine organic acids alone. Option D, liver biopsy with periodic acid shift staining and electron microscopy. The correct answer is option A, molecular genetic testing. Full sequencing of the G6PC gene for type 1A and the SLC37A4 gene for type 1B, together with deletion and duplication analysis, is the first-line test. It is non-invasive, widely available, and definitive, and once the mutation is identified, it also allows carrier testing and prenatal diagnosis. The glucagon stimulation test is strictly contraindicated because it worsens lactic acidosis and fails to raise glucose in this disease. Liver biopsy would show periodic acid shift positive glycogen, but it is now reserved only for cases of diagnostic uncertainty. Enzymatic assay on liver tissue was used historically, but it has been replaced by genetic testing. Question 8. A 15-year-old girl with glycogen storage disease type 1A is adherent to cornstarch therapy. Her labs are stable, with glucose 4.1, lactate 2.0, and triglycerides 3.8 millimoles per liter. Her last ultrasound was 18 months ago and showed no adenomas. She has no abdominal pain today. What is the most appropriate surveillance strategy for hepatic adenomas at this stage? Option A, abdominal computed tomography scan every 6 months, regardless of ultrasound findings. Option B, liver ultrasound every 12 to 24 months, with magnetic resonance imaging or computed tomography if lesions are detected or suspicious features appear. Option C, positron emission tomography scan annually to detect early malignant transformation. Option D, no imaging needed unless alpha-fetoprotein rises above normal. The correct answer is option B, liver ultrasound every 12 to 24 months, with magnetic resonance imaging if lesions are detected. Hepatic adenomas occur in 50 to 75% of glycogen storage disease type 1 patients by adulthood, and roughly 10% carry a risk of malignant transformation to hepatocellular carcinoma. The surveillance protocol is liver ultrasound every 12 to 24 months, with increased frequency after adolescence. Magnetic resonance imaging is preferred when an adenoma is detected or features are suspicious because it offers better lesion characterization with no radiation. Alpha-fetoprotein is a useful trend marker but does not replace imaging. Encouragingly, improved glycemic control may even lead to adenoma regression. Question 9. A 9-month-old boy is newly diagnosed with glycogen storage disease type 1. His metabolic dietitian and physician are planning his dietary management, and the parents ask about the mainstay of treatment. Which dietary approach is most important in the management of glycogen storage disease type 1 in infants and young children? Option A, a high-fat, low-carbohydrate ketogenic diet. Option B, a high-protein diet with amino acid supplementation and protein formula. Option C, frequent complex carbohydrate feeds with uncooked cornstarch and avoidance of fructose, sucrose, and galactose. Option D, continuous insulin infusion to regulate the glucose-carbohydrate balance. The correct answer is option C, frequent complex carbohydrate feeds with uncooked cornstarch and avoidance of fructose, sucrose, and galactose. The central goal is to maintain blood glucose above 3.9 millimoles per liter at all times, preventing metabolic decompensation around the clock. In infants, this means a soy-based, lactose-free, sucrose-free formula every 2 to 3 hours, with nasogastric or gastrostomy tube feeds overnight. In children over 1 year, uncooked cornstarch is given at 1.6 to 2.5 grams per kilogram every 3 to 4 hours, releasing glucose slowly. An extended-release starch is approved for overnight use in those over 5 years. Fructose, sucrose, galactose, and lactose must be strictly avoided because all of them worsen glucose 6-phosphate accumulation and lactic acidosis. Question 10. A 16-year-old male with glycogen storage disease type 1A presents with acute painful swelling of his right great toe. Serum uric acid is 680 micromoles per liter. He is on cornstarch therapy but admits poor compliance. What is the most appropriate management? Option A, colchicine only as needed for acute attacks. Option B, high fluid intake alone is sufficient for long-term control. Option C, dietary protein restriction. Option D, allopurinol plus dietary purine restriction plus optimized metabolic control. The correct answer is option D, allopurinol plus dietary purine restriction plus optimized metabolic control. The hyperuricemia here comes from excess glucose 6-phosphate driving the pentose phosphate pathway, then purine synthesis, and finally uric acid overproduction. So the primary treatment is to optimize metabolic control. Strict cornstarch adherence reduces glucose 6-phosphate accumulation at the source. Allopurinol, a xanthine oxidase inhibitor, is the first-line pharmacotherapy to reduce uric acid synthesis, and febuxostat is an alternative if allopurinol is not tolerated. Colchicine is reserved for acute gouty flares only, not for long-term uric acid control. And a word of caution, avoid diuretics and non-steroidal anti-inflammatory drugs in patients who have concurrent renal disease. Question 11. An 8-year-old girl with Glycogen Storage Disease Type 1b has had 4 hospitalizations in the past year for bacterial infections, 2 for pneumonia and 2 for skin abscesses. Her absolute neutrophil count on 3 occasions was 0.4, 0.6, and 0.8 times 10 to the 9th per liter. She also has recurrent oral ulcers and perianal fissures. Which intervention is most appropriate for her neutropenia? Option A, granulocyte colony stimulating factor, filgrastim. Option B, monthly intravenous immunoglobulin. Option C, long-term prophylactic antiviral therapy. Option D, bone marrow transplantation as first-line treatment. The correct answer is option A, granulocyte colony stimulating factor, also known as filgrastim. This medication stimulates neutrophil production in glycogen storage disease type 1b, with the target being an absolute neutrophil count above 1.0 times 10 to the 9th per liter. It is given subcutaneously at a dose of 2.5 to 5 micrograms per kilogram per day, titrated to response. An emerging and promising adjunct is empagliflozin, an SGLT2 inhibitor, which reduces intracellular glucose 6-phosphate toxicity in neutrophils, improving neutrophil function and reducing inflammatory bowel disease symptoms. Intravenous immunoglobulin has no role in this neutropenia, and bone marrow transplantation is reserved only for severe refractory cases. Question 12. A 22-year-old woman with Glycogen Storage Disease Type 1a returns after 2 years without follow-up. Abdominal ultrasound reveals 3 hepatic lesions, the largest measuring 4.2 centimeters. Alpha-fetoprotein is mildly elevated at 8 nanograms per milliliter. She reports right upper quadrant discomfort, and magnetic resonance imaging is performed. Which represents the most serious long-term hepatic complication of Glycogen Storage Disease Type 1? Option A, cirrhosis and portal hypertension. Option B, biliary atresia and cholestasis. Option C, multiple hepatic adenomas with risk of malignant transformation to hepatocellular carcinoma. Option D, autoimmune hepatitis triggered by glycogen accumulation. The correct answer is option C, multiple hepatic adenomas with risk of malignant transformation to hepatocellular carcinoma. Hepatic adenomas develop in 50 to 75% of glycogen storage disease type 1 patients, typically by the 2nd to 3rd decade of life. Roughly 10% of these adenomas carry a risk of malignant transformation to hepatocellular carcinoma. Risk factors include poor metabolic control, a lesion size greater than 5 centimeters, multiple lesions, and male sex. Improved glycemic control may lead to adenoma regression, while resection or ablation is indicated for large, growing, or suspicious lesions. Surveillance combines liver ultrasound every 12 to 24 months, magnetic resonance imaging with contrast if an adenoma is detected, alpha-fetoprotein as a trend marker, and good metabolic control as the primary prevention strategy. Question 13. A 19-year-old male with Glycogen Storage Disease Type 1a presents for review. Labs show an elevated urine albumin to creatinine ratio, rising serum creatinine over 3 years, and bilateral hyperechoic kidneys on ultrasound with a small right renal calcification. Blood pressure is 138 over 88 millimeters of mercury. Which statement best describes the renal complications of Glycogen Storage Disease Type 1? Option A, nephrotic syndrome with massive proteinuria only. Option B, Type 1 renal tubular acidosis, istal renal tubular acidosis, as the primary manifestation. Option C, membranous glomerulopathy from immune complex deposition. Option D, proteinuria, nephrocalcinosis, hypertension, and progressive renal insufficiency. The correct answer is option D, proteinuria, nephrocalcinosis, hypertension, and progressive renal insufficiency. The renal complications of glycogen storage disease type 1 are multifactorial and progressive. Glomerular hyperfiltration leads to nephromegaly and then progressive proteinuria. Nephrocalcinosis develops from uric acid and calcium oxalate crystal deposition. Hypertension arises from renal parenchymal involvement, and over time, in poorly controlled adult patients, chronic kidney disease can progress to end-stage renal disease. For management, angiotensin-converting enzyme inhibitors, such as enalapril, reduce proteinuria and slow renal progression, and oral citrate helps prevent stones. The clinical pearl is to begin annual renal screening from the second decade of life: urine albumin to creatinine ratio, serum creatinine, blood pressure, and renal ultrasound. Question 14. A 17-year-old male with glycogen storage disease type 1A presents with recurrent painful joint swelling, affecting the first metatarsophalangeal joint and the ankles. Serum uric acid is 720 micromoles per liter. He eats minimal red meat, and his dietitian explains that the mechanism differs from ordinary dietary gout. Which mechanism best explains the hyperuricemia in glycogen storage disease type 1? Option A, decreased renal excretion of calcium leading to urate crystal formation. Option B, excess glucose 6-phosphate shunted through the pentose phosphate pathway, leading to increased purine synthesis and excess uric acid production. Option C, increased dietary purine intake from a high-protein compensatory diet. Option D, impaired xanthine oxidase function, causing uric acid accumulation. The correct answer is option B. When glucose 6-phosphate is blocked, the excess is shunted through the pentose phosphate pathway to ribose 5-phosphate, which fuels de novo purine synthesis, and this drives uric acid overproduction. There is also a second mechanism. During hypoglycemic episodes, ATP is depleted, increasing breakdown of adenosine monophosphate, which adds a further uric acid load. And a third, lactate competes with uric acid for renal tubular secretion, so uric acid excretion is reduced. This triple hit, overproduction plus reduced excretion plus lactate competition, results in severe hyperuricemia. Treatment is allopurinol, a xanthine oxidase inhibitor, together with strict cornstarch adherence to reduce glucose 6-phosphate accumulation at the source. Before we close, I want to tell you about our community, Pediatric Case Review. This community brings all of our lectures together in one place, systematically arranged by body system, so you can find exactly what you need when you need it. In addition, every presentation is available as downloadable images, perfect for offline review and self-testing, so you can read and practice all of the questions at your own pace. New case-based pediatric lectures are added regularly across all body systems. If you would like details and to learn how to subscribe, please leave a comment below this video, and we will message you directly with access details. Let us bring this together with 6 essential clinical principles every general pediatrician must know about glycogen storage disease type 1. First, recognize the tetrad. Severe fasting hypoglycemia with lactic acidosis, hypertriglyceridemia, and hyperuricemia should make you think of this disease immediately. Second, genetic testing comes first. Molecular testing of G6PC and SLC37A4 is the first-line diagnostic test, and the glucagon stimulation test is strictly contraindicated. Third, cornstarch is life-saving. Uncooked cornstarch and frequent complex carbohydrates with strict lifelong avoidance of fructose, sucrose, and galactose. Fourth, for type 1B, the combination of neutropenia, recurrent infections, and inflammatory bowel disease is treated with granulocyte colony stimulating factor, with empagliflozin as an emerging option. Fifth, watch the liver. Ultrasound every 1 to 2 years because adenomas develop in 50 to 75% of patients with a risk of transformation to hepatocellular carcinoma. And sixth, monitor the kidneys. Screen yearly for proteinuria, nephrocalcinosis, and hypertension, and use angiotensin-converting enzyme inhibitors to protect renal function long-term. Thank you for joining this case-based review. Please follow the channel for more case-based pediatric lectures and leave any questions or topic requests in the comments below.